Good evening, and thank you for allowing us this opportunity to provide input on such a profoundly important subject. I appear today on behalf of the Coalition for Healthcare and Conscience. Joining me is Larry Worth, the Executive Director of the Christian Medical and Dental Society of Canada. We are like-minded organizations committed to protecting conscience rights for health practitioners and facilities. In addition to the Catholic Archdiocese of Toronto and the Christian Medical and Dental Society of Canada, our members also include the Catholic Organization for Life and Family, the Canadian Federation of Catholic Physician Societies, the Canadian Catholic Bioethics Institute, and Canadian Physicians for Life. I will address two issues: conscience protection for healthcare workers and palliative care and support services for the vulnerable. For centuries, faith-based organizations and communities have cared for the most vulnerable in our country, and they do so to this day. We know what it is to journey with those who are facing great suffering in mind and body, and we are committed to serving them with a compassionate love that is rooted in faith and expressed through the best medical care available. We were brought together by a common mission: to respect the sanctity of human life, which is a gift of God, to protect the vulnerable, and to promote the ability of individuals and institutions to provide health care without being forced to compromise their moral convictions. It is because of this mission that we cannot support or condone assisted suicide or euthanasia. Death is the natural conclusion of the journey of life in this world. As the author of the book of Ecclesiastes wisely observed long ago, the dust returns to the earth as it once was, and the life breath returns to the God who gave it. Death comes to us all, and so patients are fully justified in refusing burdensome and disproportionate treatment that only prolongs the inevitable process of dying. But there is an absolute difference between dying and being killed. It is our moral conviction that it is never justified for a physician to help take a patient's life under any circumstances. We urge you to consider carefully the drastic negative effects physician-assisted suicide will have in our country. Killing a person will no longer be seen as a crime, but instead will be treated as a form of health care. According to the Supreme Court, adults at any age, not just those who are near death, may request assisted suicide. Following the lead of some European countries whose experience with assisted suicide and euthanasia we disregard at our peril, the Provincial Territorial Expert Advisory Group has already gone beyond the restriction of assisted suicide to adults and has proposed that children be included. The right to be put to death will, in practice, become, in some cases, the duty to be put to death, as subtle pressure is brought to bear on the vulnerable. Those called to the noble vocation of healing will instead be engaged in killing, with a grievous effect both upon the integrity of a medical profession committed to do no harm and upon the trust of patients and those from whom they seek healing. Even those doctors who support this legalization in principle may be uneasy when they experience its far-reaching implications. The strong message from the Supreme Court is unmistakable. Some lives are just not worth living. We passionately disagree. In light of all this, it is clear that reasonable people with or without religious faith can have a well-founded moral conviction in their conscience that prevents them from becoming engaged in any way in the provision of assisted suicide and euthanasia. They deserve to be respected. It is essential that the government ensure that effective conscience protection is given to healthcare providers, both institutions and individuals. They should not be forced to perform actions that go against their conscience or to refer the action to others, since that is the moral equivalent of participating in the act itself. It's simply not right or just to say, you do not have to do what is against your conscience, but you have to be sure it happens. Our worth as a society will be measured by the support we give to the vulnerable. People facing illness may choose to end their lives for reasons of isolation, discouragement, loneliness, poverty, even though they may have many years yet to live. What does it say about us as a society when the ill and the vulnerable in our midst feel like burdens? Often a plea for suicide is a cry for help. Society should respond with care and compassionate response for these vulnerable people, not with death. Proper palliative care to date is not available to the majority of Canadians. It is a moral imperative for all levels of government in our country to focus attention and resources on providing that care, which offers effective medical control of pain and, even more importantly, loving accompaniment of those who are approaching the inevitable end of life on earth. Now, Larry Worthen will now provide more detail about some specific recommendations.
Thank you, Cardinal Collins. Ladies and gentlemen of the committee, His Eminence has provided you some insight into our concerns about how legalizing physician-assisted suicide or euthanasia will impact vulnerable patients. Provided they can consent, people with disabilities such as rheumatoid arthritis, paraplegia, or those with mental health difficulties could qualify for assisted death according to the criteria set down by the courts. Often people who have these challenges are struggling in a world with many barriers. The danger is that they will choose assisted death because of the failure of our society to provide the necessary support. Through increased access to palliative care, disability, chronic disease, and mental health services, Canada can significantly reduce the number of people who see death as the only viable option to end their isolation, their feeling of being a burden, and their sense of worthlessness. Our concern for our patients extends to our concern for conscience protection. Recently, the College of Physicians and Surgeons of Ontario passed a policy requiring referral for assisted death. A referral is the recommendation or a handing over of care to another doctor on the advice of the referring physician. The requirement to refer forces our members to act against their moral conviction that assisted suicide or euthanasia will in fact harm their patients. If they refuse to refer, they'll risk disciplinary action by the Ontario College. When a proposed practice calls into question such a foundational value of the common good of society and the foundational value of the very meaning of a profession, a healthcare worker has the right to object. A healthcare worker does not lose their right to moral integrity just because they choose a particular profession. In the landmark Carter case, the Supreme Court of Canada said that no physician could be forced to participate in assisted death. They also said that this was a matter that engaged the charter freedoms of conscience and religion. It is not in the public interest to discriminate against a category of people based upon their moral convictions and religious beliefs. This does not create a more tolerant, inclusive, or pluralistic society, and it is ironic that this is being done all in the name of choice. Fortunately, 6 other colleges have not required referral. We have enumerated several possible options for the federal government to ensure that these charter rights are respected all across the country. We have a legal opinion that we will make available to the committee that lists 5 ways that the federal government could protect conscience rights. If the federal government does not act, then we risk a patchwork quilt of regulatory practices and a serious injustice being done to some very conscientious, committed, and capable doctors. Despite our concerns, members of our coalition will not obstruct the patient's decision should this legislation be put in place. The federal government could establish a mechanism allowing patients direct access to a third-party information and referral service that would provide them with an assessment once they have discussed assisted death with their own doctor and clearly decided they wish to seek it. Our members do not wish to abandon their patients in their most challenging moments of vulnerability and illness. When we get a request for assisted death, should this legislation go ahead, we'll probe to determine the underlying reason for the request to see if there are alternatives for management. We'll provide complete information about all available medical options, including assisted death. However, our members must step away from the process, allowing the patient to seek the assessment directly once they have a firm commitment to take that path. Like our coalition, the Canadian Medical Association has stated that doctors should not be required to do referrals for assisted suicide or euthanasia. It's important to remind the committee that no other foreign jurisdiction requires physician compliance in assisted death through referral. In closing, we highlight 4 areas of serious concern: the need for improved patient services including palliative, mental health care, and support for people with disabilities. Protection of the vulnerable. Provisions that physicians, nurses, and other healthcare professionals not be required to refer for or perform assisted death or be discriminated against because of their moral convictions. And finally, protection for healthcare facilities like hospitals, nursing homes, and hospices who are unable to provide assisted death on their premises because of their organizational values. Thank you for your time and consideration.
Thank you very much. And I'll now turn to our colleagues and Madam Shanahan.
Thank you very much, Mr. Chair. My question is addressed to Monsignor Collins and Mr. Worthen. I just want it on the record. I am a practicing Catholic, although I say practicing because I'm not very good yet. And you can be assured that I have reflected and prayed on this matter greatly, both before and now during this time that I am a member of Parliament. And how I have had to make my peace with my own personal beliefs. And I know what I believe, and I know that if I'm ever faced with the choice, I'd like to think that I will be able to make the choice that my faith requires of me. But that being said, I'm here as a parliamentarian, and I cannot impose my beliefs on others. And I am very conscious of the fact that we have to make recommendations for legislation that are going to address the beliefs and values of all Canadians. So given that the Carter decision, and I am relieved to hear that you acknowledge the Carter decision, as indeed we must, what are the how do you reconcile then your approach, given that so many Canadians and Catholic Canadians look to faith-based care for that end-of-life care? How do you reconcile that end of the process of delivering end-of-life care to Canadians, and in the event that they ask for physician-assisted dying?
Well, Larry, he'll give some of the details of the. I would say, first of all, we do not agree, obviously, with the with assisted suicide and euthanasia. We think this is a direction which leads all kinds of people into tremendous suffering and is not good for our whole community. It is really a thing which causes great ultimate suffering for all of the most vulnerable, including those who are considering suicide, things of that nature. We know, though, that obviously, as you say, people are proceeding along this path in response to the Supreme Court judgment. But individuals, and I would not presume to say that I'm going to, by my words or something, stop that from proceeding. This is the parliamentary process that's in place. It is not for me to engage in it. But I would simply say that there are many, many Canadians, especially those most deeply, intimately involved in caring for people, who are profoundly troubled by our country moving in this direction. And that whatever procedures you are in the course of setting up, that those who have that profound conviction must be, I think their conscience needs to be protected. And I'm glad the Unitarian Church also agrees with that. I think not only individuals, but also institutions. There are ways of providing protection for conscience and dealing with this issue, and I think Larry has mentioned that, and I want to give more detail on that.
Yes, the proposal, which we will leave behind, was one that we discussed at length with the Canadian Medical Association, which they have approved, which basically shows the physician articulating their conscience issue around assisted suicide and euthanasia with the patient, having the dialogue and discussion with the patient, giving the patient information about all viable options, but then simply stepping back from the process and allowing the patient to have direct access to an assessment for assisted death. Our hope would be that either the federal government or the provincial governments would create an information and referral service so that after patients have had the discussion with their own doctor, that they are able to access that directly. We've checked that out with moral theologians, both on the evangelical and Roman Catholic side, and they find that morally acceptable. This seems to us to be a way for our physicians to continue to care for the patient, not affect the physician-patient relationship, and also allow the patient to make their decisions without there being any obstruction from the physician.
So you would be open to this duty to inform then, if not an active referral, but to inform another body that the patient has requested physician-assisted suicide? We
differ slightly from the recommendations of the Provincial Territorial Expert Advisory Group. They suggested that it would be the physician's responsibility to inform the third party. Our feeling is that it would be unacceptable for us to have to take that responsibility, and that the actual patient could be the one to contact. In the situation where the patient is unable to contact, which would normally happen in an institution, then we could look to a patient transfer. That would be the opportunity then for another physician in the facility to be able to respond to the patient's concerns.
Thank you. Mr. Warwa.
Thank you to the witnesses for being here. Very interesting. I researched the Unitarian Council, and I didn't see any hospitals that have been established in the Unitarian Church, but I did find many that are faith-based Catholic hospitals. There has, and I appreciate the question from MP Shanahan and her sharing that we should not impose our beliefs on other Canadians. But there's this balance of faith and doing what's right in our own hearts, too. My question is, and also there's been comment around this table, that the doctor's conscience should be protected, and maybe not to do it themselves, but to refer. And I'm understanding that you believe, and I've heard from most physicians, actually I think it was 70% of physicians do not want to have to be required to refer. 30%, which is 24,000 physicians, are willing to practice this. So focusing on the 70%, that I think most Canadians believe that they should not be forced to perform such as suicide or euthanasia. They should not be forced to refer. But there's been a question, I think, from one of our senators that institutions, BRICS, do not have conscience. If you could comment, do institutions have a value system that would say yes or no? Should they have the right to say no as an institution? And is there a possibility of having possibly harmonizing system where you have institutions, hospitals, like a Catholic hospital, that is not bound because they're providing health care, but they could be known for a hospital that provides health and natural death, and there could be some hospitals that provide that other choice. Could you comment on that?
I think it's very true to say that institutions are not bricks and mortar. You don't look around and say this is. Institutions are made of people. Institutions are like the Sisters of St. Joseph, the Grey Nuns, all the various groups who brought loving health care to this place. They're not things, they're communities of people. And they have values. That's why people come to them. That's why they seek them out. They know when they go to, for example, a hospital, like I think of St. Michael's Hospital, St. Joseph's Hospital, Providence Center, which has a wonderful palliative care place. They know they can trust when they come to the sisters, when they come to the church, and it's true as well for Jewish and Protestant similar institutions, of which there are many in my own diocese. There are very many that they can trust that we have certain values that we hold to. Those values are important for our whole society. I mean, political parties have values. Other institutions have values. They're not objective things. They're not like material things, and that's a great value for our whole community. These institutions are funded by the government because they do an immense good work. They provide variety, diversity, choice, I might say, to people. And that's very, very important. So I would say that institutions provide the spirit. I think of the one next to where I live, the Urban Angel, St. Michael's. It's a sign of hope for people. And if you would undermine the institution for what it is, our society will be very, very much harmed. Our whole community would be a lot harsher, colder, crueler, without the witness given by communities of faith who are on the ground, on the street, day by day, caring for the most needy. I don't think they should be undermined or attacked.
Anytime. 1 minute. Thank you, Collins. I'm just wondering about the safeguards to ensure the conscience. You said you had some ideas of how physicians that do not want to participate within a federal regime. I had heard that one of the suggestions was that it could be a criminal offense to force someone, a physician or an institution, to force someone to be involved with this. Is this one of the suggestions that you were considering?
Yes, our legal brief has 5 different options in all. One of them would be, just as in some of the provincial college documents, doctors who choose to do euthanasia are protected against discrimination on the part of faith-based institutions. So also we would ask that doctors who do not want to do euthanasia are also protected, and that could be by way of criminal statute that would make it unlawful for someone to be coerced to participating in this.
Or an institution.
Thank you. Mr. Rankin.
Thank you.
Thank you, Chair. Thank you to all of our witnesses. I particularly appreciate Cardinal Collins, your strong assertion of the need for our committee to address palliative care, and I really appreciate you putting that on the table. I wanted to, I guess, explore a little bit what Mr. Warra was just saying, presumably to Mr. Worthen, the question. I'm going to read to you from the College of Physicians and Surgeons of Ontario, their interim guidance. They talk about physicians must provide an effective referral, quote, to a non-objecting, available, and accessible physician or agency in a timely manner. And in my province of British Columbia, this similar body says, quote, physicians must ensure effective transfer of care for their patients. This is in the context of conscience protection for healthcare providers. Now, you've stated this obligation to refer patients would violate the conscience rights of certain physicians, and instead there should be a mechanism to provide patients with third-party information, assessment, and services. I'm a little concerned, though, because other witnesses have told us that simply providing a person who wishes to exercise their constitutional right can't be limited by a Yellow Pages reference, an 800 number, or a website. So I'm trying to get my head around what you're suggesting, and in particular, how that would affect the right of access, effective right of access for Canadians in remote communities, if one were to accede to your recommendation.
Okay, thank you for the question. It's a very good one. I think that there needs to be more. Our proposal is not to simply send someone to the Yellow Pages. Far from it. Our doctors are committed to the life and well-being of their patients. So they would want to maintain the physician-patient relationship. They would want to discuss this important decision with their patients. They would want to provide the patient, they would want to spend time determining what the reason for the request is, and they would also want to ensure that the patient was able to get the assessment if they so desired it. They would not want to stand in the way of that. I'm not talking, we should not be talking in this country about having a simple operator at the end of the phone that is going to give someone a number. In my view, we should be responding compassionately to these people because many of these people will need services, support, and help. And so this service that is anticipated by the Canadian Medical Association, I think similar in the provincial territorial expert advisory group recommendations, would be for support services to be made available and for this person to get an appropriate assessment and in a thorough way. We're not talking about sending some of the Yellow Pages. This is in a thorough way. Now, I think that something like this is really important in a more remote community, because even in a remote community, you might have one doctor or two doctors. Both might be people who are not prepared to participate in assisted death. This will mean that it would be important for that individual to be able to get access to this service. And that service, I think the responsibility is on government to ensure that that service is available and provided.
Then I can, if in the time that's available, that's so short, I want to go to the institutional side. We've talked about the conscience of the healthcare provider. I'd like to turn again to the institutional argument and to quite boldly put forward that if an institution of which the Cardinal has spoken receives public funding, shouldn't they be required to provide all Canadians with the constitutional rights that they now have? I understand about the professional, and you've put some good arguments forward, but I'm still at a loss to understand why a body that receives public funding shouldn't be required to be providing constitutional rights that all Canadians now enjoy.
I would say, just to answer that quickly, I would say that it's misreading the Carter decision to say that it requires individual physicians or facilities to provide this service. What it says is that Canadians have the right to this, but it doesn't say that they have a right to it from every individual institution or individual doctor.
There's only one such institution in a remote Northern Ontario community, for example.
Well, this happens all the time in medical care. There are certain procedures that are only provided in certain places. It would be up to government. The departments of health cannot shirk their responsibilities here. If this is something that the Supreme Court has mandated, then the departments of health have to find ways to provide these services. And if that means that they have to send a physician out to that individual or bring that physician in, that commonly happens. Like if
there's a hospital in a particular community, they shouldn't be providing that service, even though
Senator Nancy Ruth.
You have said that access should be evenly available and that doctors must transfer patients if they have a conscientious objection. What is the opinion of the Unitarian Council if the hospital is a faith-based hospital who objects to doing physician-assisted death? Not just the doctor.
We understand that there are many faith-based institutions that provide hospice and palliative care. And it's even more important in those situations that a good, effective process of transfer of care does happen, as we've been talking about, especially in the more remote communities. It is the constitutional right of every Canadian to receive this care, and it is a fine balance between protecting the rights of conscience of the physician and making sure that the rights of the individual patient have not been violated. So a good mechanism needs to exist, whether it's direct doctor referral care or a third-party referral system. It needs to flow smoothly. And I would think that if someone checks into an institution or a hospice facility that is faith-based, they would know ahead of time that there are certain moral values apply. But to go back to the previous question about institutions, if they're publicly funded, we believe that publicly funded institutions should provide this kind of assisted dying. We also believe in the sanctity of life, but we don't think that life should be extended and preserved at all costs. We believe that quality of life is really important as well. There is no dignity, there is no compassion when someone is terminally ill, they're at the end of their life, they can't take care of themselves, their bodies have let them down, they are in pain, and they can't look after themselves. There is no dignity in that. My partner died a little over 2 years ago. He was diagnosed with a condition early in 2000 and lived beyond his original prognosis. He was fortunate enough to receive very good hospice care in a hospice. It was excellent palliative care. But would he have wanted access to physician-assisted dying? Yes, he would have. He was in pain, he was uncomfortable, he was not the person that he knew himself to be. And if we force someone to prolong their life because a physician isn't willing to provide that kind of care, then we're violating their constitutional rights.
Thank you. You did say that there should be a review after death. Could you explain that a bit more?
I think a review process serves to make sure that effective mechanisms are in play. As this practice and this legislation rolls out, we're not going to know what it looks like. So in terms of helping both the institution and the physician make better choices down the road, I think a thorough review of what request was made, how the request was handled, how the institution handled it, and how the physician handled it will help both the institution and the physician.
Who is it that should?
I think it should be an objective party, whether it's a committee put together by various stakeholders. It should not be the institution that provided the care, and it shouldn't be the physician who provided the care, but someone objective.
Can you see?
And I think this is even more.
Can you see
I think
this
this
coming
is the
under the
review is
coroner's
even more
office in the
important.
provinces? Can you see the
I'm sorry,
coroner's
can you-
offices be expanded to include this kind of thing? What I'm getting at,
I
is
think
there
that's
a
a
need to
possi-
create a new institution, or can we use what already exists in every province and territory across Canada?
I think the options are there as long as there are no biases built in, as long as there's a process to make sure that the reviews are objective and that there are no preconceived agendas.
Thank you.
Senator Cowan.
Welcome to the witnesses, and thank you for your evidence. Your Eminence, I appreciate your your faith-based opposition to physician-assisted dying, but that's not the issue before us. The court has made a decision, and we're bound by that decision. And physician-assisted dying is a constitutional right for those eligible to access it, and so. And I appreciate the concerns that you've expressed about conscientious objectors and the nobody being forced to participate. But it seems to me, and I'd ask for your comments, that what we're really looking at here is we ought to be looking at it through the eyes of the affected patient, and that it's the rights and beliefs that we might have to be accommodated to meet those rights that the patient has. So I'd like you to turn, perhaps you would wish that there is not going to be a physician-assisted death in this country, but there is. So what precautions, what particular specific precautions should we be recommending be put in place to protect abuse and protect the vulnerable? And I think all of us would want to afford every protection to the vulnerable and to protect. But what specifically should we be recommending that would allow physician-assisted death to proceed, but at the same time providing appropriate protections for the vulnerable?
I'm certainly sure that there are people, many around this table and around the country, who are very much committed to assuring that physician-assisted suicide takes place. And it is a thing, obviously, after the Carter decision. This is the project of this committee. As I have made clear, I don't believe that is the direction the country should be going, and it would be far be it from me to try to, or to be suggesting making it like, should we have 3 doctors, 2 doctors, should we have 1, should we do? I don't believe it should happen. So I can't get into
understand that, Your Eminence, but that's not where we are.
I'm sure other people will be doing that, but I don't believe in the thing itself. What I do believe is that the rights of conscience of people who are constantly involved with compassionately caring for those most in need to be protected. And I also believe that alternatives should be presented, funded, and very directly, and that would be palliative care.
All of us, again, you're preaching to the choir here, because all of us would believe that there ought to be more readily accessible, better palliative care available to more Canadians. But again, that's not our issue. Our issue is, and maybe Mr. Worthen can address this issue of precisely what is it, what are these, you spoke about protection of the vulnerable as being a concern. What can we do to protect the vulnerable within a regime which permits the constitutional right of eligible persons to access physician-assisted dying?
Well, I'm with the Cardinal on this. I spent some time a year and a half ago with Dr. Theo Boer, who is a medical ethicist in the Netherlands. He was on a euthanasia commission there. Their job was to review cases. And he told me, he indicated, we went through every one of the so-called safeguards that were available in the Dutch statute. And he explained to me about cases that he had where doctors had circumvented those. Studies have shown that in one study showed that in about 20% of cases, doctors were actually performing euthanasia when they thought they were doing palliative sedation. So in my discussion with Dr. Bohr, I said it appears to me that these so-called safeguards are just there to sell the concept of assisted suicide.
Surely if there are safeguards in place and physicians or other health professionals disregard or circumvent those precautions, then that's a disciplinary matter for the College of Physicians and Surgeons or the Nurses Association?
Unfortunately, if you look at what's actually happening in these countries, doctors just get a slap on the wrist.
Well,
they get a letter. They get a letter telling them. I mean, I guess what I'm trying to say is that once you accept the idea that state-sanctioned killing of patients is morally acceptable, and you open it a crack, it becomes almost impossible to find a place to stop that process.
I don't mean to be. I don't.
Mr. Aldag?
Thank you. There we go. I'd like to thank everybody for the comments that you've shared, which is giving me much more to think about once again. I know Cardinal Collins, you'd mentioned, you may not want to be involved in forming or shaping, and so I'll put this to the other two panelists. And it's continuing with the question of safeguards. We've heard from some presenters that have come here that we should look at safeguards being medical. So if somebody decides that they may be interested, there's one physician, perhaps two physician process with a wait time to be determined. We've heard from other witnesses that they feel that this should be taken away from the medical community and moved into a legal or quasi-legal kind of piece. And I'm just wondering if you have thoughts on either of those options, or if there's another option on safeguards that we should be contemplating as we mull over how this may actually work out. Again, looking at protections for the vulnerable. How do we create that the appropriate amount of time for reflection by both the patient and the care providers, and within what field? And is there something missing that we haven't considered in that legal or medical realm? And so I just throw that out to both of you for thoughts or comments.
We've done studies of looking at the various countries that have legalized this, and generally speaking, the problem is that the problem you have is that when a patient comes to a doctor and they say they want to die, there are many different factors that could be contributing to that, and many of those could be dealt with. The problem is that if you are expecting a physician to be able to do the full evaluation required to ensure that that person is not being coerced, no other jurisdiction is willing to put the funding in place to be able to do that properly. When you say that it's a safeguard to have two physicians, in other jurisdictions, there's something called doctor shopping, where if they don't get the answer they want from the first two physicians, then they'll go on to the third, fourth, or fifth physician. And eventually you will find somebody in the jurisdiction who believes in patient autonomy to the extreme, where they will permit, they will just decide because this person wants to die, they should be able to die. So the reality is that we have concerns even with the use of the term safeguard, because it normally means whatever we can put in place to be able to salve our conscience about the fact of how these vulnerable people are going to end up being put to death. The Carter criteria that was put together includes disabled people. So it's so common for our physicians, it happens on a weekly basis, that patients say they want to die because they've had a traumatic emotional incident. They have just been diagnosed with a serious illness. They've just become a paraplegic or a quadriplegic. Any number of factors can generate in a person's mind the desire to end their life. But the question is, do we as a society have the compassion and concern to be able to put the resources in place to assist those people, or will we end up just euthanizing them and basically wash our hands of our responsibility for our fellow people.
Yeah, I did want to hear from our other panelist, which is...
Did you want to hear from Ms.
Yeah, just
Ms. Ng, would you
if you have any
comment on this,
thoughts
please?
on it, just on this idea of safeguards, and so thank you.
Ms. Ng?
The protection of vulnerable peoples is really important, and I think the assessment of competency, I think, is vital to this. We're talking about two different things here, I think. One is the protection of the vulnerable people, and also to make sure that the person seeking assisted dying is really sure that this is what they want. And that's where the careful assessment process comes in. And I think you made a good point. Maybe someone doesn't want to die, they just want to be out of the situation that we're in. And that's where the suicide assessment might come in. If there are other options to help someone deal with mental health issues in a more healthy way, then I think those should be available. However, the difference is when you're talking about someone with an irremediable illness, the road is bleak. Right. So the careful and thorough assessment is really important. The assessment by two physicians is really important. The patient needs to completely understand the consequences of this decision, both on themselves and on their family. They need to know all the treatment options that are available. And I think the key to this is that the patient must freely choose this option after considering all the treatment options, and that the request for the physician-assisted death must be made by the patient and not another party. Because when you're talking about protecting the vulnerable, there is a fear here that someone else might request the death of this patient, and we want to make sure that doesn't happen. So the request for the medication must come from the patient and not another party. And I think if the physician suspects that there's any kind of...
Thank you. Mr. Cooper.
Chair, I will provide the balance of my time to Mr. Janis.
Thank you very much, and thank you to the witnesses for being here today. Cardinal Collins, Mr. Worthen, I think you bring a refreshing perspective, and I would say respectfully, it's a perspective that I wish we could have had an opportunity to hear more of at this committee. But I have two specific issues that I'd like to raise, and I'll raise them both at the same time, if that's okay, and then leave the balance of my time to you gentlemen to respond to them as you wish. My understanding is that the idea of dignity, a word that we hear often in this committee, is very important in the Catholic tradition as well. But sometimes I think we use the words like dignity and compassion without a certain precision to them. So I wonder if Cardinal Collins, if you could talk to us a little bit about the understanding of dignity in the Catholic tradition, and give us a little bit of a definition. Of course, we would all like to see people have dignity at the point of their death, and perhaps then we need to think a little bit about what dignity really means. Then the second issue I want to hear more about is the subject of palliative care. I think all of us agree here that palliative care is good, that we would like to see more palliative care. But I think we need to go further than that and recognize that it is not just desirable but necessary to provide people with palliative care. And this was made clear by the report of the expert panel, that a request for physician-assisted death, I'm quoting here, cannot be truly voluntary if the option of proper palliative care is not available to alleviate a person's suffering. In other words, it isn't a genuinely autonomous choice at all if we continue to provide palliative care to such a tiny fraction of Canadians. And in fact, if we proceed with this and don't respect conscience for institutions, I fear that we'll see the closure of more faith-based palliative care services who aren't willing to provide this. So I wonder if you can comment both on the issue of what dignity means and also on the centrality of palliative care.
Okay, maybe I'll start with the very important point you raised concerning dignity. And I think everyone may have different opinions on that or different views. I would say dignity comes from within the person, himself or herself. I would think even a person without faith would see that in a purely human way, the dignity of the human person. It doesn't come from the circumstances around them. From the point of view of faith, it comes from those who we see people as a child of God, as someone who has inherent dignity. Every person must be treated with reverence. Did John Paul II have dignity? When he was a 58-year-old Pope skiing down mountains, he had dignity. Did he have dignity when he was in the last years of his life, when he couldn't, he had many different things which were, his body was breaking down? I would say he had dignity then, and he had dignity at the other times as well. Dignity comes from within the human person. I would say dignity comes with the reverence we give to a person, and that's why we should surround them and care for them. Think of Mother Teresa. Do the people she served, do they have dignity? Yes, they did. And she tried to help them in their suffering and care. Dignity comes from within. Dignity, I would say, comes from God. It is something that we are all, and what we are doing, and we've been doing for hundreds and a couple thousand years, is surrounding a person, reverencing their dignity. And that's why we don't believe it's right to kill them. We think that's just not right. That is not the way to dignity. On palliative care, I think we need to not only talk about it, I think it needs to be dealt with at the federal, provincial, and municipal levels. I think on certainly the private level. I can tell you in my own diocese, I can't speak for other religious groups. We have various initiatives. Just this afternoon, I got a proposal for another palliative care place that we're going to be thinking of putting in the center of Toronto. We do this. We're on the ground. We're doing it. We're caring. But I do think it would help a lot if this was funded. I mean, what are we spending money on in our country? I would think caring for those who have dignity inherent within them from the first moment of their life to the time when they go to the end of this life, at the end of their earthly journey. And so I think we need to not just talk about it, I think we need to do something about it.
Thank you very much. Senator Seidman.
Ms. Ng, if I might ask you a little more about the point you made about review after a death. We have heard, for example, that the review is very important. Data collection and oversight could then lead to a review of the legislation in an ongoing way to update, change over time. And we have heard that this could be a joint federal, provincial, territorial kind of oversight. Would you be able to, because you mentioned the importance of review, would you be able to comment on this, please?
I think we learn from mistakes. Going out, we know very little about how it's going to play out in Canadian society. Opinions are very dichotomized around this, and I think a review would serve all sides in this situation. Because if we proceed without review, we won't know what we've done well, and we won't know what we've improved. We won't know if palliative care actually may take care of a lot of the issues that people who are irremediably ill face. A review process, if it's a joint federal, provincial, municipal venture, will provide answers to a lot of the questions that we're asking now in this situation, and help us make sure that, one, processes that are working well get improved upon and get shared, and two, the processes that aren't working so well need to be improved on, especially in the cases where areas are more remote, in cases where physicians are acting on their conscience, and in cases where maybe not enough education or information is shared with healthcare practitioners. I think we cannot afford to assume that the rollout of this will be smooth.
And what kind of information could you see being collected in this approach in terms of monitoring, oversight, and then a feedback loop into the legislative process?
Okay. For example, how assessment of competency is done, how physicians have the conversation with their patients, whether or not the patients feel comfortable enough to broach the subject, knowing that there are going to be physicians who are not comfortable providing this kind of care, whether the institution has enough resources to support both the patient and its own medical personnel when these conversations are going on, whether two physicians are present, if that makes a difference in terms of the request from the patient, what kind of medication is used, whether there are requests from the patient to self-terminate, or whether the medication is going to be administered by a physician. Whether the family members are involved or not, I think, is important. And that also speaks to matters of coercion and protecting the vulnerable. Patients might feel a subtle pressure from family members to either act one way or another way. And I think that those intangibles, I think, are also important for the review process to pick up on. And one of the important things, I've talked about the equitable access, how patients in the remote areas access this care. His Eminence has talked about having a third-party referral process. In principle, we don't object to that, but if it puts more barriers and roadblocks in the way of the patients requesting this care, then, and if it doesn't work very well, then a better mechanism needs to be produced.
We have 40 seconds.
Would you see that, we have heard that nurse practitioners, other medical professionals could be involved in actually administering the process, the death for the patient. Could you see that as well?
We could see that happening as long as the proper information, education, training, and support was provided for healthcare professionals who would be involved in administering the death. We don't say that physicians should be the only one because we know that circumstances are different around the country, especially in more remote areas. So yeah, we are open to the option of other healthcare professionals being involved.
Thank you very much.
Both in administrating the medication and in being support.
Thank you very much. Thank you, witnesses, for being here with us today, colleagues for their questions, and we need to turn this around in 2 or 3 minutes for the next session, and with that, I suspend the meeting.